Hey guys, glad you can be a part of my first flipped classroom experience here at Pima. These general education classes are a good starting place for this kind of a learning atmosphere. So just follow along with the lecture and just listen to the videos with each slide and email me or come find me if you have any questions on anything. A couple of things we'll be talking about today with some key terms, definitions you'll be responsible for, what we mean by first do no harm, kind of the creed of a therapist, and then we'll talk about some different insurance programs and some different programs out there that are kind of the way healthcare is going and things that'll be important to know as we go forward. This is what we mean by first do no harm. I mean, this should be at a minimum for us, is just making sure that at the very least we're not making people worse, right? Preventable medical errors killing over 200,000 Americans every year is just way too much. I don't even need to say that. But all these different things, and now of course looking at these examples, a lot of these do not pertain to us. We're not going to be doing diagnoses and drug mix-ups and worry about needle infections too much, those kind of things. But it still is an issue that we need to be doing our due diligence and making sure that we are taking care of patients the way we ought to be taking care of them, so that we are not harming them. We're not making things worse by them coming into our clinic and being treated by us. And so a lot of places are coming up with these educational programs in order to curtail that and make sure that at a bare minimum people are keeping patients safe. Cost of healthcare is a huge issue. It wasn't always the case. I mean, cost was always an issue, but it wasn't always what predicted or dictated how your treatments ran. I remember when I was doing my observation hours before physical therapy school, the therapist that I was working for was an older guy, and he'd been in practice for 20 years or so, and was telling me when he first started therapy, they would have patients after an ACL surgery come in, and the therapist would basically tell the insurance company how many visits they need, and the insurance company would just sign the check. Obviously not the case anymore. You're lucky if you're in practice to get 12 visits for an ACL repair, and those are typically spread out over a couple of weeks, so you don't burn through them in the first 2.5 weeks. So it's becoming an issue. There's expensive procedures out there and prescriptions, and there's a lot of physicians who are doing a lot of extra procedures for just CYA. They're just covering themselves and making sure that they're not only doing their due diligence, but they're kind of going overboard. So if anybody is kind of sue happy, they make sure they take all the testing that they need and get everything and find all the parameters that might be necessary, and then some, just to try and avoid conflict later on. And so much now that a lot of companies are funding research, like you see the example here, the yearly mammograms. They're finding that those are not necessary as far as preventing breast cancer. They are for certain populations. For example, if you're predisposed to it by family history, they recommend it yearly. But if you're not, if you don't have X, Y, and Z characteristics, then they're saying that maybe even every 2 or 3 years, until a certain age, they're not really necessary. They don't prevent any extra cancers by getting them annually, is what they're finding. So there's a lot, kind of go back and forth going with the insurance companies about what are they allowing, what's really medically necessary, and kind of where's this middle ground of where we can treat them. So this slide gives an example of some of the research that we're seeing nowadays. This one particularly is from a couple of researchers over at UNLV with some of their colleagues. But just to show you that how big of a deal this is, that they're doing studies where they're just looking at cost. They're looking at treatments, and then they want to see the outcome measures and how well people did with those treatments and the cost of those treatments. And so what they're looking for is people to get better at the same rate with cheaper treatments. So, I mean, that makes sense for everybody, but just to show you that this is that big of a deal, that you look at the testing on the right side here, the imaging and the doctor's visits, PT visits, and everything that costs money after some kind of a hospital procedure, and they're looking at the different procedures here and seeing the difference in costs with, in this case, they did an experimental group where they taught people about pain science and how pain works and how they can manage it themselves. And so they were able to determine that it's a lot cheaper to teach these patients about pain science education and have them kind of manage their own pain. They end up going to less doctor visits, less PT visits, less chiropractor visits, and saving a lot of money. And so insurance companies really latch onto this because they're getting outcomes, they're getting good results with a lot less money. And so it's a big deal, and research is funded very well that is looking at healthcare expense and good outcomes with cheaper healthcare. This is another big issue of the cost that these different procedures and things will leave with the patient. So yeah, you might get great care and you might get better, but then you've got bills until who knows how long that you're trying to pay back. An example of a friend of mine who's got cancer, and he was left with the choice of, well, do I get cancer treatments and on a terminal illness and bankrupt my wife afterwards, having to pay for all these medical bills, or do I skip out on the treatments and not live as long but not have nearly the medical bills? And who wants to make that decision? So clearly there's some problems in the system that we've got, and with the cost of healthcare and the bills that come out of that healthcare system. But it's something that we're kind of left with right now. Lack of healthcare providers is another issue with our current system. You get some lower income patients that use hospitals as primary care. So in other words, we've heard stories, I'm not making these up, stories of people who have a child who is sneezing more than usual for half a day or so, and they'll bring him to the ER. That is not where you should go if you have a question about your child's care that's not an emergency. But a lot of times people who don't have any health insurance, that's where they go. They can't afford to pay a copay at a doctor's office, and maybe they can't get to an urgent care, but they can call 911, and once they respond, they're going to take them to the hospital. So it's unfortunate, and those aren't cheap visits, even if they don't get admitted. A lot of times people off the street don't have homes, and they are sick, and so they end up going to the ER. They don't have anywhere else to go, and they do get admitted, and so they're not going to pay for those bills, so somebody has to. So it kind of falls on everybody else. So there are now physicians who will not take those patients. I mean, obviously we talked about emergent situations, you have to treat them, but in kind of outpatient clinics, there are physicians who won't take Medicaid because they get terrible reimbursement, and they're worried about not getting paid on the bills that they send out to patients. So it's a tough spot for people to be in, for sure. So germ warfare is a problem once people get admitted to a hospital. So we have these 2 million people that develop hospital-based infections. They go to the hospital to get better, and they end up getting an infection there. It's not exactly what we're aiming for when we go to the hospital, is it? So a lot of the deadliest bacteria are developing resistant strains. So much that this one, MRSA, MRSA, it's in the name, it says it right there. It's methicillin is an antibiotic. So MRSA is a bacteria, or sorry, Staph aureus is a bacteria. Methicillin is usually what's used to treat that bacteria. But you have this strain now called MRSA, which is, like it says there, methicillin-resistant Staph aureus. So it's like a superbug, is what they're calling them. That you have to hit them with harder medications, which obviously does a number on the body system of a patient. So it's an uphill battle. If somebody goes in there sick, their immune system is already kind of weakened, suppressed, and then they get this MRSA or something like it, and it's really tough to treat, and they end up getting sicker for a long time. Fraud is a big issue kind of wherever you go, any profession, and certainly therapy is not exempt from that. By definition, the intentional deception or injury to another person, so people can be fraudulent on their own credentials, on medical records, they can falsify information, on billing practices, drug trials. We're not going to really deal with that too much, but just be careful when you're doing your documentation. You don't document things that never happened. Just kind of checking yourself and making sure that you're keeping that integrity that we talked about a couple weeks ago. If you didn't do that treatment, don't document that you did the treatment, even if you should have. Like you left the bed rails up. We talked about that. If you didn't do it, just kind of own up to it, and it'd be much better than if you falsify records and they come back at you later on if they find out. So better just to own up to any mistakes that you have and kind of move on from there. And certainly, if you intentionally do something that you shouldn't and you're fraudulent in some records, you need to own up to that as well. This is not a good characteristic for a therapist. We don't want to be doing fraudulent activities. This is a pretty sad, fairly recent development, a continuing problem that we've got of this prescription drug abuse. Accidental fatal drug overdoses risen 500% since 1990. It's an epidemic. Just a couple of examples of drugs that people are ending up with drug abuse and addictions to: OxyContin, Vicodin, methadone. And a big problem is how difficult it is for people who really need these drugs. They're in a lot of pain. For a lot of these, they're pain medications. To get them now, because pharmacists and physicians are so weary that they're going to get those medications in the wrong hands, and so pharmacists are very reluctant to just hand out prescriptions filled for Vicodin or OxyContin. So it's very tough for patients, even if they have a prescription for it. A lot of pharmacies will not fill them unless a certain amount of time passes, and so it gets difficult for some patients. And that certainly impacts us, because if they can't do therapy because of pain, then we're kind of up a creek. So this is a big problem that we're having to deal with. So this slide kind of breaks down the numbers a little bit for you. Last slide talked about the accidental fatal drug overdoses rising 500% since 1990. This one puts a number to that, rising from 6.1 deaths per 1,000 people to 16.3 deaths per 1,000 people in 15 years. And you notice at the bottom there, one of the physicians on this study, the rates are still going up. So this is not getting any better. And unfortunately, it doesn't look like it's going to be changing anytime soon with the people who are pushing these drugs. They're getting a lot of money for these drugs on the street. And so it's very easy for people to have an abundant supply when they get them illegally. So it's easy for them to feed their addiction. And if you take too much of a substance, you're leaving yourself up for an overdose. So big problem that we're dealing with. And then on top of all that, some people, just depending on where they live or the resources that are available in their area, don't get the same health care as other people. We could even see that in your own areas. You know, you got some places that are really affluent areas may have a nicer hospital and nicer facilities than some other areas. So that can all play into some of the disparities that we're seeing in our healthcare system. And you've got these other bullets here: lack of insurance, language barriers, subconscious bias. I mentioned before, people that are homeless using the hospitals just for heading into the ER. Well, some of them will just use them if it's cold outside. They'll just have somebody call 911 for them, and then they get into the hospital and they get put up for a night, and they get 3 square meals the next day, and nothing's really wrong with them. So that happens enough times, and then all of a sudden you're going to develop a bias against people that are homeless, even the ones that really do need treatment. So it's a tough situation to be in. So how do we fix it? We talked about all these problems, so what do we do about it? Well, this is one way. We want to promote prevention, health screenings, these kind of things before the fact. Unfortunately, insurances they're getting there, but they're not quite on board yet with funding a lot of prevention. They're starting to see the research that clearly shows that if you can prevent an injury, you're going to save money in the long run. So these kind of educational programs are starting to pop up with a little more emphasis, but it's still a lot of it's based on the treatment. You let them get sick, and then we'll pay you how much you need to treat them, rather than we'll pay you first to make sure they don't get sick in the first place. And that's going to be a lot less money for everybody involved, and obviously the patients will be happy they don't get sick. They may have to put a little work into it ahead of time, but not having to sit in a hospital for a week or a rehab center for 2 weeks or a month, they're going to love that too. So we need to change this mindset. We need to focus more on wellness, prevention, rather than treating afterwards. patients are becoming much more active in their participation in their own health care. They're getting very aware of what's going on and what diseases are around, and they rely on Dr. Google and Dr. Wikipedia to figure out what's going on with them, and they'll come into their doctor's appointments with ideas of what they need to treat, what they need to be treated with. They'll ask their doctor about certain medications and all these things, and in some cases they're right on, in some cases they're not, to say the least, but they are more aware. Regardless of their accuracy or not, a lot of them have a lot better idea of what's going on medically than they used to. We talked about this before, they have a right to look at their own chart. They have a right to be seen by an actual doctor. If they choose not to be seen by a student when you go on your clinical rotations, they have that right. They can be seen by your therapist, your supervising therapist. So those are all different patient rights that they've got, and they should be aware of those. They're usually told those when they're admitted to the facility or their first visit there. There's been an emphasis lately on these kind of robotic surgeries. They're a lot less invasive, they're very precise, and the surgeons that work them are working the robotics. It's not just like a robot you kind of push play and all of a sudden they go do a surgery. It's basically surgeon-guided surgery. The surgeon has got their arms in a device that'll move the little robotic arms, and because they can set these robots up with so many more joints than we have in our fingers and wrists, they can be much smaller instruments, and they can go in and do these surgeries and at a remarkable outcome. So I've got this link here on the bottom for a robotic surgery demonstration. Hope you'll check that out, just to show you what they can do with these robotic surgeries and kind of what this looks like. It's the patients are left with much smaller incisions and much smaller downtime after the fact. So of course there are ethical issues surrounding these robotic surgeries as well. But like I mentioned, if you watched the video, you saw that the robotics enhance the skills of the surgeon. They don't replace the surgeon. It's not just a robot. You still need the surgeon. Now, with that though, you don't need surgical techs and all these residents and different things. They're still going to be hooking the attachments up to the robot, but you don't need as many people in there. So that's totally true. And so this next point comes into question. Some employees are afraid of losing their job to machines, and rightfully so. They see an example outside of healthcare, but there was the example that I've read about in McDonald's where people were complaining about their wages. They wanted higher wages, so what did McDonald's do? They put kiosks in there, so now you can order your own food. You replace the cashier, and so that's going that way. If you're going to complain too much, or if they can find a better way to do something, they may replace you with a machine. So I don't find that happening or worry about that too much in therapy. It's a very hands-on profession. But we did talk about telemedicine. So in a sense, that may be doing that. If somebody can see 15 patients from their living room and not have to travel, that's going to save a lot of time. They can see more people in a day, which is going to take away from the amount of therapists that they need on their staffing. So it could have impact. So the government got involved a while ago and tried to curtail some of these problems that our current healthcare system had. And so they instituted in '86, again, don't worry about the years, what we talked about before, how you cannot be turned away if you go to an ER. And so that brings the problem that we're seeing now, where people just go to the ER for very frivolous things when they could probably go to an urgent care or just call a hotline and they can talk you through an issue or something like that and tell you if you really need to go to see a doctor or not. So there are certainly issues inherent with that as well. This Children's Health Initiative program, the CHIP, Care for Children of Low-Income Families. So a lot of people who are on welfare, or like it says, just low-income families, at least their children can have health care. That's the idea behind the CHIP program. So my kids had that when I was in PT school. We were most definitely a low-income family. Some of you may be in that situation right now, and your own kids might be on CHIP. So just to help make sure that those kids who can't provide for themselves, they're not accountable, that they can still be taken care of if they need to be. So this is just a list of different providers of insurance. They're different groups. A lot of it depends on where you work and the type of company you work in, what's available to you. all I want you to do is be able to recognize these as different types of providers. Okay, so you have these HMOs and PPOs, you have Medicare, Medicaid, COBRA, which is we've talked about before, is an insurance if you're left out of work for a while. So all these different options available to people. So I just want you to recognize them as insurance groups that are available to different people. You're not going to have to distinguish who gets an HMO and a PPO and all that, but just recognize that's what they are. There's a lot of different options for people, depending on a lot of different scenarios. If you're out of work, in work, if you're not making a lot, if you are making a lot, kind of in-network and out-of-network doctors, and a lot of those kind of things. So I'm going to assume that you're all familiar, at least you've heard of, the Patient Protection and Affordable Care Act, which has been, you drop off the first part typically and we just call it Affordable Care Act or Obamacare. So I'm not going to get into a debate about the supporters, the opponents, and all that. That's not the scope of this class. But it did change quite a bit of the way we have healthcare. Now, I hesitate to use the word forced because you can still get out of it, but most people are mandated to have some type of health insurance. And so what ended up happening when they first instituted this is those who already had health insurance and were generally healthy, their premiums, or the amount that they had to pay just for basic coverage every year, skyrocketed, because now you have people that were very, very sick that in years past were getting denied health insurance coverage because the companies knew how much money they would be spending on these people with these illnesses. Now they were forced, those companies were forced to accept them as clients. So those clients who didn't have all those medical problems had to kind of foot the bill for the people that did come on with a lot of medical problems. And so it was a big, big issue when it first came out, and they're trying to kind of find a middle ground, and it's a very, very hot debate on Capitol Hill as far as Affordable Care Act and what is good about it, what needs work, what needs to be kicked out, and all those things. But it's definitely a big part of our healthcare right now. This slide speaks to what I was just talking about. This is one of the biggest changes, that somebody who had a outstanding condition, like somebody with lung disease, if they were going to apply for an insurance plan, many times they would get denied coverage because insurance companies knew how much they would have to be paying for medical treatments for these people. And now with the Affordable Care Act, they can no longer be denied coverage. And so people who just need to have health insurance, just for the just-in-case moments, are the ones that their premiums have gone way, way up to be able to subsidize the cost that insurance companies have to shell out to pay for the medical treatments of those who need a lot of treatments. So this slide just highlights some of the issues that they had when it first rolled out. To be expected, initially there was no real deadline. They didn't have websites that were working all the time, and they had way more people enrolled than they had planned for, and so there was a lot of slow starts going. This last part is the one that personally I take issue with. If I want to risk it with my family that I don't have insurance, I should be able to do that. I shouldn't be forced to be on some kind of an insurance program. But that's what was part of the Affordable Care Act, is everybody needs to be covered, or you needed to pay a fine. So that's certainly a hot button issue on Capitol Hill right now. So this slide gives an example of some of the different things that the government is getting involved in. They're saying if you're on this insurance, if you're covered by insurance, you have to get certain things given to you. One of them with, of course, children with pre-existing conditions, but with the example here of birth control and abortion, now insurers must offer preventative care to female employees if they want it. So, like it says, some religious organizations are exempt from that, and there are some provisions for states, but a lot of those that are mandated to be on insurance, they can get pregnant, and so they have to offer these other services to them, where in the past they didn't, and these are not cheap services. Birth control, imagine that for each individual person times however many people are in the insurance group. This is not a cheap thing. So that's something that insurance companies are having to deal with. And of course, people try and take advantage of others. This happens all the time with new programs and implementation. They would call people and claim to be part of the Affordable Care Act staff that needed to check the information. So can you please confirm your information over the phone and give me all your info, and so I can make sure that we have it in the system right, and all those kind of bogus things that just trying to um, get information from people. And if they did get that information, then they can submit claims on their behalf, even though the treatment was never given, and Medicare would pay out. So that's a big problem they had to deal with. Uh, Understanding the Affordable Care Act is a big problem. Look down a couple lines. A 2,400-page document. Who's going to read that? I don't think I've ever read a 2,400-page document, especially not on health insurance and coverage. Oof. But there is a APTA explanation here that if you click on that, you can see that. But essentially, they kind of broke it down, and especially where it impacts therapy. So I would encourage you to go check out that link. So what's in it for our profession in the future? Well, we've got a licensure compact. I can't remember if we've talked about that or it was with another group, but essentially the licensure compact is where multiple states will agree to a common state practice act. And so if your license is good in one of those states, it's also good in all the other states that are agreeable to that licensure compact. For most people, that really doesn't matter too much. If you live in one state, you're probably going to stay in one state. But if you happen to have family in another state and you travel, you go home for a weekend, you can go treat a patient or two and make some extra cash on the side. So your license is good in that state. So it's good for people who travel. That's one of the positions, one of the many jobs you can have in therapy is you can be a traveling physical therapist, where you go work in a city or a place that has a need for 13 weeks or 4 months or whatever it is, and then you can move on to another place. So if you don't like staying put, that's a good place for you, or a good setting for you is travel therapy. And then these licensure compacts will help make it easier for you to practice in Arizona, or California, or Utah on the same license that you've got. So they're a good thing. Obviously, malpractice claims are in our way. If you're going to be doing fraudulent things, just count on malpractice coming right after you. So again, just avoid those. Move Forward PT is a website that's helping inform patients. We talked about that a few slides ago, how patients are becoming more informed, more aware of what's going on, and we want that for therapy. We would love them to come in and know what they expect and be able to have realistic expectations of therapy. So that website, and Dr. Ruskin has a lot to do with some of the articles and things that are pushed on that website. And so it's all about awareness and all about helping our patients learn. It's trying, like we talked about a few slides ago as well, that wellness and prevention rather than having therapy after the fact. This is trying to prevent them from even needing to come to therapy in the first place. And then I've mentioned this telehealth, where there's some issues and problems that may arise, but some people are working with those and trying to figure that out. But essentially, that's a Skype therapy session. So you kind of video chat in with your patient, you watch them doing their exercises, and then you give them new ones if needed, and then you're on your way. So clearly there's ethical implications there. If they're going to fall while you're watching them, well, there's not much you can do to stop that fall. So a little bit nerve-wracking, but it's kind of the way that healthcare is going, especially for kind of easier maintenance patients that just need you to check up on them. And there's no need to drive 35 minutes, 45 minutes to go see a patient, and then drive another 25 minutes to go see another one, when you could do telehealth, which would get you to both places. You'd have more time with each patient, not feel as rushed, but they're still getting therapy from an actual qualified therapist, instead of just hoping they remember their exercise program right. So it certainly has its place. It can be a very good thing for patients as well.